Hi, I am so elated to meet you in the program of 1 minute please. What is SGLT2 inhibitor? How it plays a pivotal role in executing cardiorenal protection? As compared to other anti-diabetic agents, SGLT2 inhibitors have demonstrated that it is capable of reducing hospitalization for cardiac failure. It is capable of reducing major adverse cardiovascular event, including cardiovascular death. In fact, it can reduce albuminuria and it can reduce or retard the progression of chronic kidney disease. How it executes cardiorenal protection? So let us see. So what is SGLT? So SGLT is nothing but sodium glucose cotransporter. So these transport proteins are two types. One is sodium glucose 2 transporter and sodium glucose 1 transporter. Sodium glucose 2 cotransporters are predominantly present in the kidneys. On the other hand, sodium glucose 1 cotransporters are present in the kidneys, intestine, heart and skeletal muscles and so on. In the kidneys, sodium glucose 2 cotransporters present in the proximal part of the PCT. Okay. On the other hand, sodium glucose 1 cotransporter present in the distal part of the proximal tubules. Please remember that 90% of our filtered glucose is absorbed by this sodium glucose 2 cotransporter. Only 3 to 10% of the glucose is absorbed by this sodium glucose 1 cotransporter. So what SGLT2 inhibitors do? So SGLT2 inhibitor inhibit the function of the SGLT2 transport proteins. So what is the consequence? When SGLT2 is inhibited, 90% of the filtered glucose is not absorbed. So glycosuria occurs. Glucose is excreted in the urine. Since it is glucose and sodium cotransporter, sodium also is excreted in the urine. Then apart from sodium and glucose, water also is excreted on the basis of osmotic diuresis. So there is excessive excretion of glucose and sodium and water. When glucose is abnormally and excessively excreted in the urine, resulting in calorie deficit. So when calorie deficit occurs, then patient is able to lose weight. So SGLT2 inhibitor execute weight loss, moderate weight loss by 2 to 2.5 kg over 3 months. One. And second one, since it causes excretion of water resulting in diuresis. So what is the consequence? Because of diuresis, then there is water depletion, intravascular volume depletion or otherwise called hypovolemia. That is very helpful in failing heart. In failing heart, when somebody suffers in cardiac failure, the most important treatment is you have to dilate the vein or otherwise called preload. So you have to dilate the vein. So what happens? Veins are not able to pump the blood from the venous circulation into the right atrium. That will give much relief to the failing heart. So the most important part of treating in heart failure is you have to reduce the preload. So we introduce always two important drugs, okay, in reducing the preload by dilating the veins. One is furosemide. We all think that the furosemide causes relief in pulmonary edema by excreting water. Please remember that injection furosemide, before it acts on the kidney, it dilates vein across the body. So venous return, the venous blood is not able to be drained in the right atrium. So venous return comes down. So the failing heart has much relief. Then one more drug, okay, during the time of crisis of pulmonary edema, one more drug what we are giving is injection morphine. So morphine causes powerful venodilatation by which it reduces pulmonary edema, something like injection furosemide, but it is more potent than furosemide. That you have to remember. So ultimately the most important is you have to reduce the venous return, or in some other way you have to reduce the intravascular volume. That will give much relief to the heart. That's why we always advise fluid restriction in the case of cardiac failure. Here SGLT2 inhibitor since it excretes more and more water secondary to glucose and sodium excretion, it gives much to the failing heart. So that is the one reason why it executes very favorable results in cardiac failure is one, because of excessive water excretion in the form of urine, and second one, since there is abnormal excess urine, your BP comes down. So SGLT2 inhibitor is capable of reducing blood pressure by 5 mmHg. So because of reduction of this 5 mmHg in systolic blood pressure, that also one favorable point for cardiac failure. 2. And third one, what they claim that when you have glycosuria, what happened? The calorie deficit occurs in our body. That causes weight loss. So usually the initial weight loss due to SGLT2 inhibitor is contributed by water depletion. The later part of the weight loss is contributed by because of excessive glucose excretion in the urine. When calorie deficit occurs or when you have glycosuria excessively and abnormally, what happens? There is no need of excess insulin secretion. So when you don't have glucose in the plasma because of glycosuria, what happens? The insulin secretion comes down. When insulin secretion comes down, what happens? The ratio of insulin glucagon is altered. So here the insulin secretion comes down when you use SGLT2 inhibitor. At the same time, the glucagon secretion may be normal, so there may be a relative excess of glucagon. So the ratio of insulin and glucagon is altered in those who consume SGLT2 inhibitor. So what is the beneficial result when you have reduced glucagon at the same time relatively normal or excess glucagon? That causes metabolic switch. I mean, what happened? The SGLT2 inhibitor produces relatively some kind of artificial starvation in our body. When you have starvation, what will happen? Our body will try to utilize fat as an energy substance. So those who use SGLT2 inhibitor, what happened? Because of this alteration of insulin glucagon ratio, okay, fat is converted into fatty acid, okay, in the fat, I mean in the adipose tissue. So adipose tissue releases more and more fatty acids in the plasma. These fatty acids are extracted by the liver or taken up by the liver, where fatty acids are oxidized for the energy. When fatty acid oxidation occurs, the end product is ketone bodies. You are all aware that ketone bodies also one of the energy substances like glucose. Now, the failing heart has multiple options. Either it can use ketone bodies as an energy substance, it can use glucose as an energy substance. So what is the difference between the usage between this ketone bodies and glucose? What I would like to insist that if you use glucose as an energy substance, that requires more oxygen, okay, to produce ATP from glucose. When ketone bodies are utilized for energy, myocardium can utilize less amount of oxygen to produce ATP from the ketone bodies. So that will give much relief to the heart. So instead of using glucose where your oxygen demand is more, the already failing heart utilizes the ketone bodies for production of energy which requires less amount of oxygen. So there is every chance this failing heart is able to thrive in the case of when somebody suffers cardiac failure. That is the reason it is able to bring down almost 30 to 35% relative risk reduction in hospitalization for heart failure. Beta hydroxybutyric acid is considered as a most important vital substance in our body because beta hydroxybutyric acid acts like a signal molecule and it exerts anti-inflammatory activity. In fact, it reduces the oxidative stress. So because of all the reasons, SGLT2 inhibitor execute cardioprotective mechanism. One, it exerts weight loss that is beneficial to cardiac patient. It reduces preload by excreting excessive water in the form of urine. It reduces the blood pressure by 5 mmHg. The most important is it allows myocardium to utilize ketone bodies with preference to glucose, especially during the time of crisis, which requires less amount of oxygen. Now, how SGLT2 inhibitor helps in reducing the albuminuria, how it retards the progression of chronic kidney disease. As I told you earlier, when SGLT2 transport protein is inhibited with the drug, what happens? There is an abnormal excretion of water, there is abnormal excretion of sodium, and there is abnormal. When sodium is not absorbed from the proximal tubule, what happens? More and more sodium is delivered to the distal tubule. So those who take SGLT2 inhibitor, the most important, the pathophysiology is the whatever sodium that is supposed to be absorbed from the proximal tubule is excreted through loop of Henle, then more and more amount of sodium is delivered to the distal tubule. So what is the most important consequence when more and more sodium is delivered to distal tubule? When more and more sodium is delivered to the distal tubule, this is sensed by macula densa, or otherwise called specialized distal convoluted tubule, due to which it secretes adenosine. So the more and more sodium is delivered to the distal tubule, so distal tubule senses more and more sodium, so because of which adenosine is secreted. This adenosine causes afferent arteriolar constriction. That's the most important point. So when you constrict afferent arteriole, so what is the benefit for us? How it reduces your proteinuria? Please remember that when someone develops the state of diabetes, so naturally your plasma glucose goes up. So that person maintains high plasma glucose, for example 400, 500. When you have been maintaining glucose level 400, 500, what happens? Naturally our kidney also filters more and more glucose. So when more and more glucose comes into the proximal tubule, that puts lot of pressure on the proximal tubule to absorb the excess glucose filtered by the kidney because of diabetic status. So our proximal tubule produces more and more SGLT2 co-transporter. So what happens? There will be enormous sodium absorption in diabetic patient, those who are not on SGLT2 inhibitor. Just once again I try to repeat, when somebody maintains high glucose level 500, 600, the glucose will be excreted in the proximal tubule. So you have more and more glucose is delivered in the proximal tubule. So our body produces more and more SGLT2 transport protein in the proximal tubule. So the enormous production of SGLT2 co-transporter absorbs all the glucose and sodium and water, it tries to absorb. So when more and more sodium is absorbed, what happens? There will be decreased sodium to the distal tubule in diabetic patient, those who are not on SGLT2 inhibitor. When you have decreased sodium delivery to the distal tubule in diabetic patient, those who are not on SGLT2 inhibitor, the consequence would be the adenosine production. Adenosine production is reduced. When adenosine production is reduced, what happens? The afferent arteriole will be dilated. So what is the end result of afferent arteriolar dilatation? When you dilate afferent arteriole, more and more blood flow to the glomerulus. So there is increased blood flow to the glomerulus, causes increased intraglomerular pressure. When you have increased intraglomerular pressure, what happens? The proteins are secreted into the proximal tubule, resulting in albuminuria or proteinuria. So the most important pathophysiology mechanism here, in diabetic patient, those who are not on SGLT2 inhibitor, decreased sodium delivery to the distal tubule, resulting in less amount of production of adenosine, results in afferent arteriolar dilatation, so more blood flow to the glomerulus. So there is increased intraglomerular pressure, more and more protein excretion in the kidney tubules resulting in proteinuria. So when you introduce SGLT2 inhibitor, what happened? Sodium is not absorbed, sodium is excreted. Now more sodium is delivered to the distal tubule. So what is the consequence? When you deliver more sodium to the distal tubule, adenosine is secreted. When adenosine is secreted, afferent arteriola vessels, afferent arterioles are constricted. When afferent arterioles are constricted, what happens? There won't be enormous blood flow into the glomerulus. So intraglomerular pressure comes down. So proteinuria comes down. So this is the way it improves renal function. So by various mechanisms, it executes key protective mechanisms in protecting our heart and kidney. I sincerely hope you are benefited with this program immensely. Thank you.